Good morning, everyone. I'm going to be talking today about a case that we might be seeing in clinics, often hidden, so we're going to call it the hidden culprit. So this patient was a 27-year-old male patient that has been treated for 3 years for redness and itching that increases at night with a burning sensation, received drops of a combination of antibiotics and corticosteroids topically, and every time he stops his drops, it recurs again. Now, this is an aggressive case of Demodex, if you've already have seen, but you can see the very tiny collarettes along his lashes. This patient, it has been extreme because it has been there for 3 years and given so much corticosteroids that it became resistant to treatment. And you can see the concentrated collarettes along the lashes. So the organism is Demodex, and there is Demodex folliculorum that's related to the lashes, and brevis related to the sebaceous glands in patients with rosacea and seborrheic dermatitis. The life cycle of Demodex is 14 to 18 days, going from eggs to larvae to adults, which is important when we administer oral ivermectin in these cases to be aware of the life cycle of the Demodex. It overgrows also in immunocompromised patients, so we keep that in mind. Our patient is a bit an extreme case. Usually the cases come in this appearance, and they can be easily missed if we don't search for it under the slit lamp in any patient with blepharitis. So you can see they're very tiny cylindrical organisms along the lashes, and they're part of the normal flora, so they might be easily missed. So the treatment, the gold standard now, and it's good that in the past years the treatment is available in the Egyptian market, yes, on and off, but it's there, is the tea tree oil, and we're going to be talking about it in the next slides. Topical ivermectin as well, some Blefex, and we're going to go through the lines of management. So the first line of treatment is tea tree oil. 50% tea tree oil is extremely irritating. It's not available in the Egyptian market readily as medications, but the medical name is Melaleucia alternifolia. I'm trying to pronounce it, but it's extremely irritating, and we use it, or it's recommended to be used only weekly and not daily. Whereas a terpenine 4-ol, which is a form of tea tree oil, less irritating, can be used as form of daily scrubs, and it's present in multiple forms in the Egyptian market. Yes, sometimes it's available, sometimes it's not, but the main form of it is terpenine 4-ol. And they're also available in form of wipes, and you can tell the patient either to bring a Q-tip and spray the spray right on it and brush along the lashes, or use the wipe over the Q-tip and also go over the lashes because they're acaricidal, where they will kill off the mites. I found this in literature. I've not used it personally in practice, but it has been shown that ivermectin 1% can be used off-label on the lid margins nightly for 2 to 4 weeks, and it has been showed evidence that it causes 85% reduction in mites as well. The next treatment that has been used in aid is Blefex, and it removes the Demodex mechanically, but it is not acaricidal on its own, so it's better to be used in correlation, or to place the tea tree oil on the Blefex wand while doing the brushing, and concentrate at the roots of the lashes when doing. However, the American Academy guidelines, they do not recommend Blefex as the first-line treatment, but only in cases of refractory or resistant collarettes, and the use has shown that we need to prioritize the acaricides first before Blefex as well. So this was our patient. He had a refractory case, and after one session of Blefex removing, you can see the removing of the very aggressive Demodex collarettes, and that it's preparing the lid to take the acaricidal a bit better than the very aggressive form initially. Adjunctive therapy has also been reported in literature with hypochlorous acid. Unfortunately, it's not present in the Egyptian market to my knowledge, like Avenova or Blefadex. Baby shampoo diluted has been reported. I don't recommend it very much. It causes a lot of irritation to the lid in itself. Warm compresses and mechanical debridement can be used, but we use the Blefex more commonly or with the wipes. For refractory cases, oral ivermectin 200 micrograms per kg is recommended in 2 doses based on the life cycle 1 week or 2 weeks apart, and this is for the severe cases. Now, there has been also evidence on emerging therapies like IPL, the pulse light therapy. It disrupts the mite habitat and can be used in cases of refractory Demodex as well, in form of 3 sessions, 2 weeks at 2-week intervals. Topical metronidazole, 0.75% is also under study. It's not available in the Egyptian market. Some points to keep in mind: avoid steroids. They worsen the mite proliferation, as we saw in our patients. If the patient has coexisting conditions like dry eye or rosacea, to be treated as well. Mites are contagious. I have a family, a mother and a son, that both have Demodex, so this is important to avoid sharing towels, makeup, and so on. There are still, however, gaps in evidence regarding what is the threshold of mite density that requires treatment, since we know that it's a normal part of the flora. If the patient is a contact lens wearer, she should continue it during the treatment because the tea tree oil will cause damage to it. And for the pediatric cases, 5% tea tree oil only is safe. There's no data on ivermectin as well. I wanted to summarize the treatment in this slide as a step-by-step treatment protocol. So if you're not sure of the diagnosis, we can do an appellation and confirm it under the microscope. Initially, we can use in the PM 50% tea tree oil scrub weekly, or the more readily available terpenine for once at night. And this is from weeks 1 to 4 for the first 4 weeks. And then we maintain with wipes 2 to 3 times weekly. If the case is refractory, we can add Blefex to it or oral ivermectin and consider IPL. I'd like to thank my professor, Dr. Mohammed Shafiq, for guiding me through ocular surface in general, and thank you very much.